but you need to explain to the patient they need to come back for another session in a week, and you keep doing it until you fully eradicate it. So the Mohs surgery is a procedure basically that's been described for the excision of malignant tumors. They map it microscopically, and they basically they define the extent of the in other words, they're operating with a microscope. They're knowing exactly how far they need to go. And this is probably for basal and squamous cell carcinoma of the skin. There's another procedure called Dermabrasion, and it's just rotating mechanical heads, like wounds the skin and down to the dermis. It's just like removing whatever you want to remove with mechanical force. A lot of money. So laser, you guys know what laser is. It's basically, just wanted to cover the basics. Okay, so you guys familiar with acne? Familiar with eczema? Familiar with seborrheic dermatitis? Where do you get, where do adults get seborrheic dermatitis? Scalp, nose, sometimes in the ears. It's like dandruff. How do you treat it? Selsun Blue or like ketoconazole shampoo, or for those that are more severe, you can prescribe like steroids, lotion. Contact dermatitis, pretty sure you've seen it. Always look at the distribution of something, like either a watch or a belt or like a necklace, whatever. Tinea corporis, I show you guys pictures of that, and remember it's scaly. Remember I described that to you guys. Then we have the onychomycosis. I'm sure you've seen it. It doesn't get better, only you need systemic treatment. In the urgent care, you can't treat these patients because you need to do several refills and you need to do LFTs. So this is more like a primary care. You can prescribe like a tincture of miconazole or terbinafine, like you were describing, but at the end you need to tell the patient, we're gonna try to treat it, but very likely this is just not gonna go away unless you take the systemic. And the systemic, you need to supervise those patients. So I don't recommend that you guys do that. You need to do LFTs. HSV, are you guys familiar? Last week I saw a lady who was presented with very painful genital ulcers, and I told her like, this is HSV. She says it's impossible. I've never had this. I only had one partner, and I culture it. And in the urgent care, it's very easy. Just request a viral culture. The nurses know where it is, and swab it. And 3 days after, she was growing HSV. And she was always in a lot of distress because she didn't know how she got this from. Varicella-Zoster, the primary lesion is chickenpox. The subsequent presentation is shingles. So you need to be familiar with shingles. Remember, examine the skin. Seborrheic keratosis, it's very common in kids and also in elderly. Like they get like these oily plaques. And they get, not in kids, in the elderly, they get just like black, oily lesions, like they're flat, they're like little plaques, they're hyperpigmented. And have you guys seen pictures of seborrheic dermatitis? Let me just show you pictures real quick. So you need to be familiar with this one. I didn't include that one here. Not to be confused with seborrheic dermatitis, right? Mm-hmm. We call that SK, and SK is pretty common. It's pretty common in the elderly. Okay. You can actually, if you feel the lesion, it feels oily. Say it again.
They always say they can like try to scrape them off, but then
right.
It doesn't work.
Exactly. It's very common. You're going to see this, and you're going to see elderly people seeking care for these kind of lesions because they get concerned. They think it's melanoma. It's very classic. I'm sure you've seen old people with these kind of lesions. Very common, right? Yeah. Mm-hmm. It's not dangerous. You just, hold their hands and say, like, you're going to be fine. You don't need to do anything for this. But make sure you recognize that on the board. And don't confuse it with seborrheic dermatitis. It's more like kids. Okay, and then AK, you guys know AK, are you familiar with actinic keratosis? So it's a precursor for squamous cell carcinoma, and it's, you know, one of the phases of like sun damage, skin, you know, sun damage. And then skin cancer, obviously, we have like, you know, the squamous cell, the basal cell, and melanoma. That's a whole chapter in dermatology. Yeah, so acne, I'm gonna skip this. You guys know basically how it looks like. We all suffer from it at one point. These are the comedones. Important things you need to know: do not prescribe how do you pronounce it? Tretinoin, because you need to be in a database to be able to prescribe that stuff, and you need to have a pregnancy contract with the patients, like the female in reproductive age, because it's highly teratogenic. So I never prescribe that. Like if you want to just give something for the patients, you can either do doxycycline, or you can prescribe like the clindamycin topical, which is effective as well. But the treatment of this needs to be done by the dermatologist. There are different treatments for papulopustular acne. They have like, you know, I'm not familiar with these things. I put them in, I list them in here, but this needs to be treated by a dermatologist. Okay, so who didn't have this? Okay, so for severe, you do either tetracyclines or minocycline. It can cause, some of these medications can actually cause like photosensitivity, like photosensitizing. So if you're prescribing it, you need to advise the patient to stay away from the sun. And you can also prescribe oral contraceptives. They're very effective. Or spironolactone. That's one of the uses of spironolactone among many. This is like the black comedones and the pustular lesions. For severe cystic acne, you do the isotretinoin. It's category X. So I've never prescribed this thing, but I'm just letting you guys know. This is severe cystic acne. Okay, and the Acne Rosea, this is common, by the way. It's just the patients look like this red flush appearance, and like middle-aged men or female, usually more women, and patients can actually have like enlargement of the nose, like what we call a rhinophyma. In alcoholics, people with Acne Rosea can actually have it. There's no comedones. They may have an ocular involvement in severe cases, and you treat this with topical flagyl. Have you guys seen it? This is pretty common. So if they ask you that question on the boards, this is not seborrheic dermatitis. This is Acne Rosea. Okay. There's involvement of the nasolabial folds. It doesn't spare that, and attacking the nose and attacking the face, and it can attack the eyes as well. This is an extreme case of rhinophyma. I'm sure you've seen this. This is the ocular rosea. You see there's hyperemia, and you see this telangiectasia of the lid. Yeah, sometimes I get these patients going, like seeking care in the urgent care as well. So I want you to get familiar with this entity. Eczema, it always comes in the package of a very allergic person. So you get a good history, and basically, if it's presented in the early age, you're probably going to be dealing with this for the rest of your life. And if you see a lot of eczema, you think about alcoholism in adults. That's how it looks like. It's a plaque, remember? This is a nummular eczema. I think they call it nummular because it's like, resembles like a coin. We treat it with basically topical steroids, antihistamine. Sometimes you use like topical calcineurin inhibitors. And there is for these two medications, there is actually a questionable association with development of lymphoma. But this is what transplant patients, kidney transplant patients, get orally. So I don't really think that's probably significant, clinically significant. Seborrheic dermatitis, like I said, there's scaling, and these are erythematous patches. They involve the nasolabial folds. If they show you a lupus rash, the lupus rash spares the nasolabial folds. Whereas this condition, the same as the Acne Rosea, that condition actually involves the nasolabial folds. And it can affect the chest and the groin and the pubic area and the axilla. So we already talked about the treatment. It's responsive to treatment, but most patients actually require lifelong therapy because the lesions go and they come back. Topical urea works very well for this because it dries, it just gives like emollients, and it just prevents this inflammation, chronic inflammation. For patients with the scalp disease, like you said, Selsun Blue or ketoconazole shampoo works very well. It's a classic seborrheic dermatitis in the ear. And the treatment, we talk about this, non-fluorinated in the face and the ears, and non-fungal anti-yeast cream for the skin involvement. And for those severe cases, we prescribe topical calcineurin inhibitors. Psoriasis, we talk about it. This is the Kubner phenomenon. Couldn't remember table that we were talking about? That's the Kubner phenomenon. It's basically just like you pull it out and then you start bleeding. And that's basically, they may describe that in a vignette. They're not going to tell you it's called the Kubner sign, but they may describe it in the vignette. That's why it's important you remember about that, because it's pretty much pathognomonic of psoriasis. In the ring. Okay? This is the pitting, classic pitting of the nail bed in psoriasis. The treatment, I already told you guys, the UVV or the PUVA, and patients can actually get this basically the new monoclonal antibodies. Tinea, you guys know this is very common. You're gonna get a lot of like yolk itch, or pityriasis rosea, or pityriasis versicolors. You guys know what the versicolors is? These people that are like with these very, very small hypopigmented macules, like in the torso or in the back. It's quite common in coastal cities, like people that are exposed to the ocean. That's a very common organism in tropical countries. And it's very easy to treat, but it's contagious. And for some patients, it can actually leave permanent hypopigmentation after you treat it. This is basically, this will be equivalent of like a joke itch, I guess. And easy to treat. And if the patient has like severe disease, you may consider like systemic agents. You can prescribe fluconazole, but that usually should be done in the office setting. Okay, onychomycosis, very common, 13% of the US population. Most patients are asymptomatic, and then they usually show it to you on the way out. Hey, by the way, doctor, I have this. Okay, I already closed my encounter. So, but for you guys in the urgent care, like you need to tell them that you need to basically probably get systemic therapy. You can prescribe something, but I'll tell you, it's unlikely that you're gonna cure this kind of problem with just with topicals. And on your boards, if you get multiple nails, onychomycosis, what do you think? If you have a patient with all the fingers with onychomycosis, what kind of disease do you think of? HIV. Yeah, I may give you a question like that. Okay. So, yeah, so some dermatologists do a nail biopsy, but that's like one time I used to have a ferret and my wife didn't tell me, and she took it to the vet. And the vet, my wife showed up with a $140 bill, and it's like, what the hell is this? That's more expensive than the actual rat. And then, oh, like he saw like some scaly lesion, and he wanted to see it was a fungus. Like, what the hell? just put clotrimazole and that's it. You totally got ripped off. Thank you for calling me. So, but that's what they do in dermatology. Oh, let me biopsy your nail. See what it is. Like, dude, it's obvious. You have freaking fungus there. Just treat it. What else could it be? So, contact dermatitis, it's just common bread and butter urgent care pathology. Try to basically remove the offending agent if you're able to identify what it is. But sometimes it becomes very challenging to treat, and I refer them for dermatology. Classic locations. This person probably had glove contact dermatitis. For your boards, you try to follow the distribution, either of the belt, the gloves, the necklace, the waistline. These patients have like this classic distribution. Okay, HSV. For the first time that you get HSV, it can be very painful. You can have systemic symptoms, recurrent symptoms. It's painful, but it's not. You don't get the systemic symptoms that you get the first time. Very painful lesions. This is in the buccal. How do you call this? Buccal commissure. Commissure. How do you pronounce that?
I said buccal, but I've heard
Buccal commissure. Or I don't know if I'm pronouncing it right, but it cannot necessarily be there. So if you have like vesicular lesions on someone, you're not sure, very easily just grab the viral culture and send it. You know, you have that tool available in the urgent care. Okay, so treatment, like I mentioned, you do acyclovir and you tell the patients to drink a lot of water, right? And suppression, you can prescribe it for patients. You know, this is one of the few things that I give refills when I see the patient in the urgent care, because I know they're probably going to need it, and I save them a trip. And I always tell them to drink a lot of fluid. But some patients require suppression, especially for those with severe recurrence, or immunosuppressive conditions, or recurrent genital herpes. That's probably more like an outpatient, like primary care setting. Zoster, you guys know about Zoster. We talked about it. Sometimes patients can have like the severe gangrenous zoster, immunocompromised host, or even motor paralysis, but I've never seen neither of those last two that I mentioned. Classic symptoms. There is a general belief in Latin American countries that if the thing goes around your waist and all the way to your stomach and it just both sides, you're gonna die. So it's gonna kill you. So they come and they're freaking out like, oh, this is getting close to kill me. Just tell them like, no, that's not it. You're gonna have a lot of pain. Exactly. Can you please stop it? A patient was telling me, can you please stop it from growing? My mom told me if I go on the other side, I'm gonna die. So yeah. So Ramsay Hunt. You're gonna get a board question on Ramsay Hunt. So patients with Ramsay Hunt syndrome is basically a zoster of the canal. So when you do an otoscopic exam, like say a patient is presenting with severe pain, this is one of the things that I want you guys to, you're gonna see this and you're gonna remember me. I've seen it many times. When you have a patient presenting with severe ear pain and no other pathology, and then you look at the eardrum and the eardrum is perfect and the patients are like, this is horrible, please take a second look. If you see vesicles in the ear canal, that's Ramsay Hunt syndrome. And that's basically, the patients can present with tinnitus, vertigo, and they have ipsilateral hearing loss. And the reason why they have hearing loss is because it's basically herpes for the facial cranial nerve, for the seventh cranial nerve. And there is one of the branches of the seventh nerve is the tympanic, I think it's called the tympanic cord, or the tympanic. There's like a little branch that actually innervates the eardrum. And when you develop the herpes in that branch, there is paralysis of that nerve, so the eardrum cannot contract and relax depending on the noise. That's how we transmit noise. So very carefully look at the canal when patients present with severe pain. Okay. Remember we talk about ophthalmicals, so you're gonna do a fluorescein exam. Don't let this patient go without documenting that. Treatment is the same thing, just analgesia is very important that you guys think about these patients because it's quite painful. So send them home on either tricyclic antidepressants work for this kind of neuropathic pain, or you can prescribe gabapentin. If the patients have advanced kidney disease, you can prescribe it, or no more than 300 milligrams. But usually you start with 100 milligrams 3 times a day, and patients can actually go up as tolerated. And then don't be shy on giving them narcotics because this is it's really painful. This condition is very, very painful. Patients always want to have something topical. There's no such a thing because studies have shown that the topicals are not effective in any way. In fact, for the longest time, people were prescribing like topical acyclovir. I think that was already pulled out of the market because I don't think we prescribe that anymore. But just reassure them, don't do anything, don't poke it, don't scratch it, just leave them alone. Gabapentin is effective because neuropathic pain. Also tricyclic antidepressants. Sometimes patients, you can prescribe carbamazepine, but I recommend that you stay away from that because you need to have for some groups, they're prone to develop hemolytic anemia unless you have a G6PD assay. So it's just more and you need to have a baseline CBC, and a tricyclic antidepressant is pretty inexpensive, easy and cheap to prescribe. and he provides relief, but I most of the time I just do gabapentin and opiates. Okay, so we talk about this is it. AK, we talk about this, 20-30 years, patients actually, after the severe sun damage, like people had a lot of fun in the beach, then they start showing up with AK, and they need like frequent, like they get like cryotherapy of these lesions, and it's so classic that dermatologists don't send it for pathology. They know that this is a precursor lesion for primarily squamous cell, so they treat this by burning it. The 3 most common skin cancers. Basically, we know that these patients have like basal cell is primarily is the most common from the basal cell. There's several types. There's nodular, there is shiny bump, there is like a patch, there's an open sore. There's very different patterns of basal cell carcinoma. I'll leave it for your review. So these are 5 warning signs. It's a very classic location for this kind of tumor. This is the nodular basal cell carcinoma. It's like an indentation there with a telangiectation and a nodule. This is classic basal cell carcinoma nodular type. And the treatment, like I said, surgery, most procedure for the most part. And now we have like Aldara, which is a very immunomodulator that's used for this type of cancer. And it's also used for warts, very effectively treating warts with this medication. Squamous cell is the second most common. Sun is probably the major cause, but it can metastasize like more than basal cell. And these patients, they have a relationship between actinic keratosis and development of this. And in males, you can actually see this in the penis. It's called Bowen's disease, and obviously it can be pretty mutilating, the treatment of this condition. And warning signs, obviously a patient with an open sore, like very slowly growing lesion that is not going away, should always get biopsy. This is another example from probably a tobacco chewer or tobacco user. The finger, very destructive. And when it's that destructive, the lesions, they can actually metastasize distantly. These patients get treated with chemotherapy when it's like generalized. They usually use cisplatin or carboplatin if they have kidney disease. It's a difficult disease to treat when it metastasizes. Melanoma used to be the most ominous and feared cancer ever. I don't know if you guys heard about President Jimmy Carter. Have you guys heard about President Carter? Okay, President Carter developed metastatic melanoma stage 4 with brain metastasis, and he was treated with one of the new immunotherapy agents. He's completely cured. So this disease is one of the diseases that has been incredibly revolutionized by this new immunotherapy. If you guys haven't read about immunotherapy, I recommend that you actually read about it, because this is very novel and it's the future of oncology. This is a melanoma. So I put there, like, this is the name of the medication, it's Keytruda, pembrolizumab. It blocks the PD-1 pathway, unleashing immune cells to attack the metastatic cancer cells. This is proven to be extremely efficacious in stage 4 melanoma, and now they're conducting trials for those patients suffering from stage 4 non-small lung cell carcinoma with some promising data. This is the future of medicine right here, immunotherapy. There's actually, if you guys enjoy leisure reading, there's actually a very good article in the New York Times about immune therapy, how the historical background. The guy who envisioned this, he lived in the early 20th century, and no, actually in the late 19th century. He felt that the way we should approach cancer was by stimulating our immune system to attack it. So he was purposely infecting patients with infections so they can mount an immune response to attack the tumor. Everybody made fun of him. He was like the guy was a joke. His research was ridiculized. The guy was like in the back of history. Back in the 60s, one of the doctors started like like really get into his theoretical background, and he started like doing a lot of experiments. And the guy who discovered this, he's riding a Porsche. I saw it in the New York Times with a license plate with the name of that PD1 pathway. This says PD1 pathway or something like that. So you should read it because it's beautiful, and this is the future of medical oncology. This is such a hot topic in medicine, internal medicine right now. And I encourage you guys to do some reading so you can impress your attendings when you go back. Okay, so a couple of questions and I'll let you guys go. Go ahead, Emma.
Sorry. A 70-year-old male patient presents to your office for a routine checkup. When examining him, you note the following lesion on his back, which measures 9 millimeters in diameter. So he states that this lesion has been there for years, but thinks it may have gotten larger in the past 1 to 2 years. He states that the lesion never bothered him. In fact, he gave it very little thought over the years. After completing your physical exam, what is the most appropriate next step in the management of this patient?
What is that?
A basal cell carcinoma?
Are you sure?
No.
Look at that. Very, very, very dark, hyperpigmented, regular shaped. What do you want to do? Observe the lesion, refer the patient to a surgeon,
Take it out.
do a scrape biopsy in the office, do nothing. This is a benign lesion.
C. I wouldn't know. Sorry, B.
B? D?
B.
B is in boy?
Yeah.
You guys all agree? Question 2, and I'll tell you in a minute. Go ahead, Cable.
85-year-old male presents to office coloration of rash in the forehead. The rash began 8 days ago. Emergence of the rash was preceded by 2 or 3 days of burning pain, followed by vesicular eruption. Pain is 10 out of 10, blurry vision, decreased hearing. Next best step is...
It's the rash. So you know what it is, right?
the herpes.
Okay.
B.
Very good.
16-year-old female presented to your clinic because of acne. She states she has tried numerous over-the-counter products with little effect. She states that she is sexually active for her boyfriend and her use condoms almost every time they have sex.
Almost. That's all you need.
For example, you note cystic acne on the face and trunk with both open and closed comedone, which of the following is not appropriate treatment in this patient.
Yeah. 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 You have to be on birth control, not just condoms. Okay. Very good. So these are like a lot of the resources that I use. The answer to the melanoma is surgical, immediate surgical excision by a surgeon with wide margins. That's basically how we treat it. Okay. Questions? I'm sorry guys, it was long. There's another talk. I'm not gonna be able to. It's already 7:30. I need to get out of here. But the other talk is ENT. I want you guys to read it. It's very useful information. Maybe if I come like next week, I don't know. I have to see when Dr. Ben-Zur comes. We can do that one because it's very useful for you guys in the urgent care. Like ENT is like so common there. Yeah. Very good. Questions?